And a quick review of Complications and Notes on Imperfect Science by Atul Gawande. This was written in 2002. I was disappointed with this book, actually. I thought it would be more technical because I was interested about the kinds of problems that happen during surgery. But this book was far more on medical ethics and some of the problems in the profession, especially a fairly glaring problem to do with misdiagnosis and deaths because of it. Something like a third of all misdiagnoses could have resulted in the person surviving if it was found out what they really had. But I'll get to that. I'm going to go through a few of the parts of the book that I thought were worthwhile dealing with medical ethics first, and then I'll mention about the problems with the profession's numbers, especially also later. There was some studies done on using medical equipment like CT scans and all that, and that did make a difference to do with misdiagnoses. So, but anyways, a few medical ethics issues. So this is on page 24, and I'll quote. By traditional ethics and public insistence, not to mention court rulings, a patient's right to the best care possible must trump the objective of training novices. We want perfection without practice, yet everyone is harmed if no one is trained for the future. So learning is hidden behind drapes and anesthesia and the elisions of language. So the main point there is who wants to be the patient that is seen by the resident or by the med student who wants to do a patient history, and who wants to be the first patient on the surgery table getting their gallbladder removed? Well, the answer is no one. No one wants to be that first patient. Everyone believes that especially if they're paying for it, in Canada you don't have to pay for it, you don't have to pay for most things, but I know in the States I guess you still do for a lot of things. If you're paying thousands of dollars for some kind of surgery, you're not going to want a resident. You're going to want someone with 30 years of experience. You're going to want an old white-haired doctor, right, that's done this surgery for a long time. But what do you do with the new doctors? How do they get practice? Now, how much learning and experience can you get on simulators, on computer programs, and on cadavers? Is that really enough? And how do we then slowly bring in those new doctors, those new surgeons who are going to gain those 10 years, 20 years, 30 years of experience? How are they going to gain that experience unless they're working on patients? And nevertheless, those first year, 2 years, 5 years, and I guess forever, those patients are at risk. Those patients are more likely to have scarring from surgery because of the surgeons not being as adept with the tools. They're more likely to get infections. They're more likely to die on the table, all because of having to train these doctors. Now, obviously, there's always a more experienced doctor in the room, but that doesn't mean that doctor is the one holding the scalpel. I'm sure that the resident and the first-year doctor, they're the ones who are going to want some practice overseen by, being supervised by a veteran doctor. But nevertheless, there's still, that person has that knife in their hand, and problems can occur. But so what do you do with that? It may be possible, though, in the future that simulation techniques are good enough that new doctors can gain experience and move quite seamlessly into dealing with real patients. It may very well be that technology fixes that, and technology really may even make obsolete doctors with diagnosis and with certain robotic surgery tools. And they already have those kinds of things, automated cutting using computers, and I think they already have things like that. But so anyways, there's one kind of interesting question about, well, who wants to be the guinea pigs for these new doctors? And very much related to that, this is on page 26, and I'll quote, "The pace of medical innovation has been unceasing, and surgeons have no choice but to give the new things a try. To fail to adopt new techniques would mean denying patients meaningful medical advances. Yet the perils of the learning curve are inescapable, no less in practice than in residency. So here's the dilemma. Would you rather have a surgeon, let's just stick with surgeons, would you rather have a surgeon who has 30 years of experience, or would you rather have a surgeon with 5 years of experience but has new tools or techniques? The 30-year surgeon has far more experience, but they're using inferior techniques, the kinds of techniques that they may have learned in medical school, quite frankly. I don't know how much professional development is really done. But really, even if there is professional development done by doctors, the question is, would you rather have a doctor who's very good at using a technique or certain kinds of scalpels or tools for a long period of time? Or would you rather have a doctor who has far less experience but is using better tools or techniques? And techniques, but I mean strategies for certain surgeries, certain cutting techniques, whatever that might be. Whether they remove the appendix in a little bag, which I've seen done, a little plastic bag, or they pull it out without the plastic bag, or there are various techniques. But anyways, what would you rather have? And that's the question. And if technology is moving so quickly, and if we believe that patients should get the best techniques and tools possible, that nevertheless means that every doctor is going to be very inexperienced, because if they're always having to upgrade and to learn a new technique that some person discovered, some research was done, and this new technique is better, has better outcomes, that doctor will have to spend time learning it, and therefore they're somewhat back to square one. The transfer of their old skills to their new skills certainly happens, but nevertheless they're still learning a new skill, and so they're not the 30-year surgeon anymore. So that is another interesting question. And here actually is a case example of this. This is on page 28. There's what's called the Senning procedure, and it has to do with some kind of heart surgery. And this new Senning procedure was invented in 1986. And what happened was it was found to be better, but the learning curve did some damage. And it says here the first 70 surgeries with this Senning procedure resulted in a 25% death rate, which is pretty high. But after they learned this and mastered it, that came down. So then after 100, the next 100 switch operations with this Senning procedure, only 5 died out of 100. So it's 5%. So 25% to 5%. So you can see that learning a new procedure, the death rate actually is higher than the old one. But once the new one is mastered, the new one is better. Well, obviously, or they wouldn't bother to change over, right? But is that okay? Who wants to be a patient on these new procedures when the death rate is higher? Wouldn't you select for the other one? I guess it depends on all the details, but you see the kind of the problem here is that who wants to be in this higher risk camp? Because for the future, these doctors will be better at it, but in the meantime, someone has to take a higher risk. I should also mention, I remember reading in the book, I don't know where it is in the book, but I remember he talked about a certain institute, I think, a medical institute. They had a team of surgeons that only removed gallbladders, nothing else. And since they specialized, that team, they had better outcomes than other hospitals that removed gallbladders. So that also says something about we have people who are dedicated to doing one thing and one thing only, and therefore they get tons of experience doing that one thing, cutting that one place all the time, dealing with that part of the body all the time, and they're able to see the strange things that happen during some of those surgeries, versus someone who is a generalist, who does all kinds of surgeries and really is never able to focus on one thing. Here's something that I think is very troubling with the basically decision making in the medical field. This is on page 43, and I'll just kind of paraphrase it. There was a study done, and they found that giving doctors judgment to diagnose and to select various medications and to kind of use their patient history and kind of to use all the information they possibly can to judge the circumstances for a patient. Basically, their risks, what they should take, all these things. That process was studied, and I guess they confined it to a bunch of different diagnoses. So they have some controls in the study. And they pulled a whole bunch of doctors and looked at the data, and they got a number in terms of misdiagnoses and death rates and all that. They then tried what's called blind algorithmic approach. And this blind algorithmic approach looks at numbers only. It looks at, okay, you have this patient, you have these things in your patient history, like you're a smoker, or you have heart disease in your family, or genetic things, or whatever it might be. It takes various data points, and it looks at outcomes, and it calculates it in a big algorithm, and it produces a result. That process is superior in diagnosing and in prescribing and in survival rates than doctor judgment. Is that not insanely troubling that a computer, given statistics, can calculate better odds for you than a doctor's experience and judgment and wisdom, if they have any? I think that's insanely troubling. And it reminds me of a TV show called House MD, where they portrayed a genius doctor. And this genius doctor, who was House, his last name was House, he was the one who people went to when they had rare diseases that no other doctors could figure out. Or they tried other doctors and they gave them prescriptions and they didn't work, or they made them worse, or whatever it was. And this genius doctor had his own little department called the diagnostic department in this hospital. And by the way, there are no diagnostic departments in the universe, or in the world. This was only in this one hospital because of this genius doctor, because apparently every doctor is supposed to be able to diagnose at a minimum. But of course we know there's all kinds of rare occurrences and all kinds of misdiagnoses, which I'm going to get to, that obviously suggest that not all doctors can diagnose. But anyways, this algorithm apparently is superior than most doctors, which made me think of that show, because this genius doctor, he was the one who could beat the odds. And in most of the cases, he wasn't perfect either, but in most of the cases, he could figure it out. Him and his team, I guess I should say, him and his team could figure it out, and was superior to this algorithm that would have just said, well, given your family history and given your lifestyle, you have a 10% survival chance. You're not going to get this. We're not going to give you this prescription. We're just going to send you home. Like, that's what the computer would suggest. Or someone like House MD could be like, well, actually, I think you've got this problem. So no, you don't have a 10% death rate. We're going to try this. But you can't find those people, apparently, according to this study. It's very hard. So anyways, that's something maybe to look up. I will give you what the study was in case you're interested. It says here the psychologist Paul Meehl, and the last name is spelled Meehl, in his classic 1954 treatise, Clinical versus Statistical Prediction. He describes a study of Illinois parolees that compared estimates given by prison psychiatrists. Oh, great. No ethical problems there. Prison psychiatrists that a convict would violate parole with estimates derived from a rudimentary formula that weighed such factors as age, number of previous offenses, and types of crime. So you can look that up if you want. But apparently this computer program was able to predict better outcomes, whether these people would violate their parole or not, versus these psychiatrists, these prison psychiatrists. No doubt, and I remember when I was reading this, I was thinking, yeah, prison psychiatrist, not exactly the dream job. I'm sure the psychiatrists working in a prison are not the best psychiatrists in the world. That's not exactly the dream job. Here's just a quick little thing I thought was interesting. It's on page 135. It says here that overall women with moderate to severe morning sickness have a lower rate of miscarriage than women with mild nausea or none at all. Isn't that strange? But that's just something I thought I'd mention. Another quick little thing I marked when I was reading it. It says here that excessive potato eating is a problem. There are toxins in potatoes that cause neural malformation in animal fetuses. And it says here that that probably accounts for why Ireland has the highest rate of neural defects such as spina bifida because of Ireland's heavy potato consumption. Just another little random fact. Here's something I think that'll floor you. This is on page 170. This is about excessive eating. It says here that jaw wiring, for example, can produce substantial weight loss, and patients who ask for the procedure are as motivated as they come, yet some still end up taking in enough liquid calories through their closed jaws to gain weight, and the others regain it once the wires are removed. Isn't that great? You can have your jaws wired, so you can't chew anything, I guess, right? I think that's nuts. But anyways, here's I think the good part. He says, we are a species that has evolved to survive starvation, not resist abundance. Now this is great. This is a good little part here. I think we forget that most of our genetic life, most of our forget the consciousness, just think of the biology. Most of our biological existence has been under precarious conditions, under conditions of starvation and harsh weather and predator animals and predator other people too, violence and warfare against other tribes, and most of our biology has suited us to a harsh environment, an environment in which food is not at the grocery store, it's out there walking around, you have to go and get it, and some days you don't bring anything back, or you have to you forage and you eat poisonous berries, and your stomach has to deal with that and not die from that. That's the kind of environment that our bodies are used to, and when we're taken out of that and we are placed in a far better and peaceful world, our biology and our instincts and our impulses betray us. They incentivize or they influence us to do things that we don't need to do. We don't need to overeat. We don't need to eat every time. We shouldn't have this stimulation we do from sugars and fats, because way back when, if you were to find a primitive apple, whatever that looked like, a primitive pear. Some people don't know that all the fruits and vegetables and plants that we have today, at least the ones that are farmed, those have all been genetically manipulated. The banana of 20,000 years ago does not look like the banana of today at all. It's been modified. It's been not, and that doesn't mean chemically modified. It just means selectively bred to look a certain way. But anyways, there is so much plucking us out of that harsh environment into this kind of almost utopia breeds a lot of problems to do with our impulses. That those impulses worked just fine in the past, but now they're a bad thing. If you were to capture, if we had a time machine, if we were to capture a Homo sapien, right, like a primitive, we're Homo sapiens of course, but a primitive man, even a Homo erectus or a one of those, if we were to capture one and bring them here and civilize them somehow, they would eat and drink, and they would be a wreck. They would not be able to control their appetites because their existence had been of absence of commodities, of goods, and so they had to survive there, and they wouldn't survive here so well because things are very different. Our biology has not caught up with our technological and more civilized world. And so we have problems like obesity and diabetes and just everything, lots of things because of that, because our bodies are not suited to this existence. And what it means is that what must overcome that is our willpower. Our willpower then must grow even greater to combat the impulses and needs of our bodies. In the past, as our bodies grew stronger to deal with reality, today our minds must grow strong to deal with our biology, I guess, our lineage, our history. And what do you do with that? It'd be nice if our biology could evolve just as quickly as our civilized world has evolved. It's evolved so much faster. But anyways, that is a good point. Probably the best in the book. Looking back at our roots and seeing what has led us to survive as a species and not get wiped out by something. Our survival advantage in the past. The question is, will it allow us to continue that existence in the future? And another way to put it might be certain starting conditions. Do they permit us to have a future? Or are those starting conditions merely getting us to step 2, but step 3 kills us, right? And some people might even say that the expanding consciousness of our species compared to other animals, for example, our expanding consciousness has been to combat this old technology of our bodies adapting to a harsh reality. Those instincts and impulses let us survive then. But a greater consciousness, a stronger willpower, that is what must that must be our survival tool today, our mind, not our body. Our body was in the past for the most part. But nowadays it's our mind. Okay, and now the last part. This is on the really bad statistics that I was floored about. Although these statistics are from the late 90s, so it's a bit dated. And so this is on page 197. How often do autopsies turn up a major misdiagnosis in the cause of death? I would have guessed this happened rarely, in 1 or 2% of cases at most. According to 3 studies done in 1998 and 1999, however, the figure is about 40%. A large review of autopsy studies concluded that in about a third of the misdiagnoses, the patients would have been expected to live if proper treatment had been administered. And I'll continue at the bottom of the page. They went back into their hospital records to see how often autopsies picked up misdiagnoses in the 60s and 70s, before the advent of CT, ultrasound, nuclear scanning, and other technologies. And then in the 1980s, after those technologies became widely used, the researchers found no improvement. So I think that's pretty troubling. And I think it may be our fault. I think most people respect their doctors. They think they're good people. They think they're smart people. They don't really want to question them or the profession. They tend to think like the AMA or the CMA in Canada, the medical associations, that they have handled it. That for anyone in our society to deal with the medical, the health fields, that these associations, the AMA or the CMA, they're supposed to, quote, handle it, so we don't have to worry about it. But when you have statistics like this, when you have data points like this, are they handling it? Is this the best we can do? So those are just a few quick points from Complications, a Surgeon's Notes on Imperfect Science by Gawande. And like I said, I was hoping for the book to be more technical about what happens in surgery, but it was really more of a medical ethics book, and it had a few glaring statistics.